Polypharmacy is identified as taking more medicine than is necessary to treat the clinical condition appropriately. 9 or more medicines was chosen because statistically, you're likely to have an adverse drug reaction at that point. It's almost guaranteed. These days, we have so many different diseases to treat optimally that requires many medications. It's pretty easy to get to 9 or more medicines if you're following all the guidelines. The art is to know when to stop certain medicines, what medicines take priority, knowing how medicines interact. And that's where some of the art of medicine comes in. When do we start cutting back these medicines for the benefit versus the risk they give you? Almost everybody is familiar with the dangers of antipsychotics in nursing home patients. They're a blessing and a damnation. For the right individual, the right time, they can be a blessing. We tend to overuse them if we're not very careful. They're basically an experiment of one every time we use them. You have to watch the benefit, the risks, get them off the medicine as soon as you can, make sure you're using the lowest dose possible. All these medicines, if you look through your PDR or any bad list of medications, you'll find they have a lot of problems. They can invoke Parkinsonian side effects. They significantly increase the risk of falls. They slow your reaction time. They can literally drug you. It's a dangerous medicine that has to be used appropriately at the right time in the right place. A patient who becomes psychotic, delusional, upset and can't cope with the world, but needs a little bit of medicine and all of a sudden they're better, as long as it's carefully planned out, discussed with the patient, the family, and everybody knows the risks and benefits is okay. We fall down because that's not frequently done the way it should be. Medication review is very important. There's actually guidelines in the state operating manual and the standard of care. It needs to be done on admission. With every transition of care, if they're coming in and out of your facility, going to home care, going home, whenever you change where you're living, you do a medication reconciliation. And everybody just assumes they need this medicine. They leave it on board, and nobody thinks to try and taper it. And slowly the patient develops Parkinson's symptoms. They fall, they don't eat. Everybody's saying, well, that's just dementia progression. It's not the dementia progression. We're poisoning that patient. And until you think to try and take it off and see what happens, you don't know if you're actually poisoning the patient or if this is really the natural progression of the disease. Unfortunately, almost every physician, every nursing home has seen a case like this where we thought a medicine was necessary and found out it wasn't, and we were inadvertently causing harm. Medication reviews are also done quarterly, and then with a significant change in condition. Since change in condition can be related to medicines, one of the first thoughts is, did we accidentally hurt this patient by giving them a medicine and not enable them, but disable them?